Welcome to Module 2 in the course Identifying Patients in the Sepsis Gray Zone. In Module 1, which I would encourage you to take as the modules were built sequentially, we discussed the foundations of sepsis diagnosis and the role of lactate. In this module, we continue our journey of identifying patients in the sepsis gray zone and review the latest clinical trial research, biomarkers, and the utility and safety of procalcitonin in guiding management. I am joined today by two doctors, Dr. Patrick Cullinan, who's a critical care and emergency physician in San Antonio, Texas, and Dr. Amy Campbell, who's a quality nurse specialist in Greenville, North Carolina. I'll allow you to introduce yourselves better to the listeners. Amy?
Sounds great. Thank you. So I'm Amy Campbell. I'm a quality nurse specialist. I've been a nurse for 24 years. I work in Greenville, North Carolina, Eastern North Carolina, and I'm currently in 9 different hospitals. And my specialty and my focus is improving sepsis care.
Thanks, Amy. I'm Patrick Cullinan. I originally trained in internal medicine and emergency medicine, and then went on to do a critical care fellowship. I started my career as a dedicated surgical intensivist covering all surgical specialties other than burn. And then I transitioned over to San Antonio approximately 13 years ago, where I have a variety of roles. I work in a university teaching facility in a neurosurgical ICU. I also work in an open ICU where I take care of both medical and surgical cases. And then I also work in a variety of emergency room settings to include facility-based and freestanding. And the reason I share all that with you is because I try to use the tools that are available to me to take care of the patient that's directly in front of me with the facility that I'm at. And they vary location to location. And so hopefully I can share some of the uniqueness of the environment and how I use these tools differently depending on where I'm at.
Excellent. Thank you so much, both of you, for joining us today. In Module 1, we talked about a 68-year-old African-American patient. And Amy, would you like to recap and talk to us about what's happened with this patient?
Yeah, I'd love to. So one of our goals as we do these modules is to make it conversation and for it also to be an unfolding case study. So we first looked at this patient that was severe sepsis and looked like we were all in that pathway and not maybe going into septic shock. But now new things have developed, and he's come back with a lactic of 4.2. Now, Dr. Cullen, what would you be thinking with these symptoms and the role? How could we use biomarkers?
Yeah, that's a great question. And the first thing I would say is you have to always start at the beginning. Mm-hmm. And it isn't just biomarkers, no biomarkers, or an elevated lactic acid. You have to understand the patient in front of you. So I think the first thing I would say, one of the highest lactic acid levels I've ever seen was 21. And yet I went in to see the patient. Wow. And the individual was talking to me. They looked fine. Their blood pressure was good. They weren't tachycardic. I was like, something's not right. Well, there are different types of acidosis. There's a type A and a type B. Now, classically, when we're talking biomarkers and elevated lactic acid, our brains immediately go to type A, which has to do with lack of perfusion. But it turns out that glucophage in the face of acute kidney injury changes the way lactic acid is processed in the liver. And so it turned out that he had been sick. He started getting dehydrated. His creatinine had climbed, and he was on metformin and continued to take it because he needed to treat his sugars. Mm-hmm. So even though he had a lactic acid of 21, it was a type B, which is a clearance problem, which is not nearly the same. So I would argue that before I move on to biomarkers, I have to understand the patient in front of me and what am I seeing clinically.
So you mentioned anaerobic, and that's so interesting because we hear a lot with sepsis, time is tissue, and to think about, how are the organs being affected and if there is organ failure. You mentioned it just a little bit, but can you talk a little bit more about what's going on in the liver? And also, what other tests would you be wanting to order on this patient?
Yeah, that's great. So let me expound just a little bit more about this elevated lactic acid. So as I had mentioned in the last slide, type A versus type B. Type A is a lack of perfusion. So that can be from a bad heart, cardiogenic. Mm-hmm. It can be vasodilatory, for a variety of reasons. It could be hyper or hypothyroidism. It could
Right.
be, right? So it could be adrenal insufficiency. It could be dehydration and intravascular volume that's down. All of those are correctable, but you have to understand what you're treating, because more volume in a decompensated congestive heart failure is only going to worsen or exacerbate your condition. But now let's talk about the type B, which is actually getting more and more common in our society. Classically, when I think of type B, I think of either a mitochondrial problem, the inability to actually utilize oxygen or perfusion that's being delivered, which would be glucophage is a classic one. Cyanide poisoning can actually affect the mitochondrial level and the offloading of the oxygen and the utilization. But it also is in liver disease. The number one reason for liver failure in our country is fatty liver, non-alcoholic steatohepatitis. Why is that important? Because if my liver is not functioning like it should, then I get a lactic acid that's elevated. So I'm going to take that just a step farther, which is 2/3 of our population are obese or morbidly obese. And thiamine deficiency is a big player in our chronically ill cases, end-stage renal disease, chronic kidney disease, poor absorption through diet, also chronic acid suppression. Let me expound on one more step, which is obesity is actually starvation in the face of calorie excess. They actually are poorly nutritioned, but they have an excess of calories. So a lot of times when I see lactic acid that's marginally elevated and the rest of it looks good, and then I do all the right things for sepsis and sepsis management with fluids and assessment and antibiotics, and it still stays up, it pushes me to understand that maybe this is a clearance problem, and I'm using high-dose thiamine to help with that portion of it. More to come on that, but the literature out there and the microbiome within the gut and that part of sepsis, which is starting to be looked at, is going to be a big player as we move into this next decade.
You make a great point about really casting that wide net, not just always sepsis, even though I do have a bias of thinking, oh, it's sepsis, but there's so many other things that can make the body present one way when it's not that cause and effect of what's actually going on. So now we're going to play a little bit of a game, just talking about the promise, the pitfalls, and the potential of the biomarkers that are out there right now when you're trying to treat sepsis. So the ones most of us are very familiar with, the procalcitonin, the CRP, IL-6. Can you tell me a little bit more about these and like when you've seen them really work well for you?
I'd love to. So the gray hair shows I've been around a while, and IL-6 was traditionally known as just a research tool. And there is some great research in rat models looking at cecal perforation. And they found that IL-6 at the 6th hour of the event predicted mortality. The higher the IL-6 at 6 hours, the greater the mortality. But the problem is that IL-6 can be elevated through a variety of triggers, both viral, trauma, bacterial, of course. But that part of it, you have to understand when you're looking at IL-6, it's non-discriminatory. There's a variety of things that aren't treated with antibiotics, the classic sepsis that we are thinking about and talking about. IL-6 then becomes the stimulus for CRP. So the higher the IL-6, the higher the CRP, which gets generated in the liver. Okay, well, if a variety of things can raise IL-6 that are non-infectious, then that means there's a variety of things that can raise CRP that are non-infectious. So now you have to move into sensitivity and specificity of a test. How are you using that information? Are you trying to make sure you don't miss anything, high sensitivity? Or are you trying to actually make the diagnosis high specificity? And then how you use that information in your assessment of your patient. So Bayes' theorem basically says that if you have a low incidence of a disease within a population, and then you use a moderate or high risk group, but the test is very sensitive, even if it's negative, you have this missed opportunity of patients that you should have cared for and didn't. So it gets very tricky. The example I like to use for this is the D-dimer. D-dimer we classically think of for blood clot evaluation, whether it be deep venous or pulmonary embolus. But the problem that you have is that it's used for screening for high sensitivity. So if I take a patient that has a moderate or high risk and I get a D-dimer and it's negative below the threshold, well, I could have a false negative that puts my patient at too great a risk. So I had a mentor that used to say a fool with a tool is still a fool.
Yeah.
It's critical that you understand, one, what are you trying to accomplish? Two, how are you using that biomarker? And then fitting your patient biomarker and its testing threshold into your case scenario. If you'll humor me, I'd like to give you one more example.
Absolutely.
So BNP, when it came out, I think I was a third-year resident. And I had a number of attendings tell me, I can smell heart failure when I walk into a room. I don't need a test to tell me that. Okay. Well, if that's how you use that tool, then maybe you're right. But I've found that I use BNP for a variety of things that are outside of heart failure, but also inside of heart failure. For instance, I use BNP for concerns of PE. Because if I have a large PE and they have no history of heart failure, but I make a right heart strain dilation, then I have an increased production of my BNP. Okay. It turns out that if I use a threshold of 500 for BNP, it gives me about an 86% specificity. But if I raise that threshold to 1,000, it raises my specificity to about 93%. So just by using the same test, but changing the thresholds, changes how I evaluate that patient. And lastly, because I told you I was a surgical intensivist that managed trauma, patient comes in, hemorrhagic shock, hypotensive, and we then begin to volume resuscitate them because we have their bleeding under control. The permissive hypotension is removed. And the next thing I know, they're 3, 4, 5 liters in, and they're still hypotensive. Well, there's good literature to show that if I get a repeat BNP or a BNP, and that BNP is under 80, it shows that I still have not adequately volume resuscitated them because I do not have a stretch on that ventricle and heart to generate BNP production. So now, instead of starting them on pressors, I may choose more volume. But if I get that BNP back and it's 200, maybe they're vasodilated from the cytokine storm from the hemorrhage, and really a short course of vasopressors is the better answer than more volume. So I hope that I've answered a few of those, dealing with IL-6, CRP, and then procalcitonin, if you'll humor me a little bit about that. So procalcitonin is really nice because the stimulus for it, and I want to make sure that for the novices out there, procalcitonin is used classically for calcium regulation. Endocrine systems have a positive feedback loop, which is nice. It allows the system to tightly regulate your system, whatever one it is on. But the extrathyroidal procalcitonin is stored in the tissue, the gut, the liver, the brain, the lung. And its release is through TNF alpha, which is through bacterial stimulus, which is different. Now, there is a little bit of procalcitonin released with viruses such as COVID, some of the strains of influenza, but it is not to the same extent. So I think there's more slides that I want to get more into depth, but I want to leave that kind of hanging out there for more discussion in the slides to come.
Wow, great review. So you mentioned it a little bit, you already touched on it some, but let's talk a little bit more about where there are pitfalls in the biomarkers when you're thinking about sepsis and using these three.
Sure. Well, the pitfall is not understanding that procalcitonin is released in a all or none fashion in the extrathyroidal tissue. So there is no feedback loop, and that's important to understand. More importantly, I think, is that any trauma does damage to tissue. So if I take somebody for neurosurgery, I take them for bowel surgery, I take them for appendectomy that's perforated, right? I take them somewhere and do something that is iatrogenic in trauma. I will have an escalation of my procalcitonin. That is from trauma. It's not infectious. And we know that the half-life and the release of the procalcitonin, and I actually pulled 5 papers on all, I told you I was a surgical intensivist across the board, trauma, vascular, cardiovascular, neurosurgical, everything but actual burn. And so I decided I was going to try and figure this out, because is it different surgery to surgery? And it turns out that all the papers that I read were the exact same, which is procalcitonin after the surgery will be elevated. How big the surgery will dictate the elevation it goes to. And they all were back down to baseline at 48 to 72 hours. And so the reason that became important for me was that when I was in a surgical ICU, patient came in, got antibiotics for X. They started to get better, finished their course of antibiotics, and now they're still in the ICU because they're sick from other reasons, and they spike a fever, and they get hypotensive, but they haven't recently gone to surgery. Can I rely on that procalcitonin to help guiding the initiation of antibiotics? We'll talk more, but that would be one of the pitfalls, is not understanding some of the things that generate procalcitonin elevation. And I've already talked about CRP and IL-6 and how they're generated through non-infectious causes, non-bacterial causes.
Yeah, I think you've done a great review. Now, just to sum it up, what are some of the potential with these?
Oh, the potential is great. As I said, one of my biggest roles was trying to do antibiotic stewardship. Everybody believes that there is no cost to antibiotics, and I don't mean financial cost, though that is one of them. If you look at DRGs for the care of patients, one of the largest portions of the cost of caring for a patient is the cost of the meds. And so if there's ways that we can reduce without hindering the outcomes, right? So I'm not talking about we're putting the patient at risk. I'm talking about how do we care for that patient just as effectively with a lower footprint? What does that do? Well, globally, right, within a country, you have a given pie. And we don't like to talk about medicine as money or that, but in order to care for patients, there is a given size to that pie. And so how do we help more people with the same size pie? Well, we spend that money more effectively, more efficiently. So to me, that was one of the big things. And then let's look at some of the secondary costs, which are in drug-resistant pathogens that drive up different antibiotic exposure, or the secondary nosocomial infections that occur, such as Clostridium difficile and C. diff from broad spectrum antibiotic use or prolonged antibiotics. So if there's ways that I can either avoid antibiotics, reduce how long you're on the antibiotics, or more importantly, stop antibiotics when they're no longer necessary, then all of those help us do the best for the patient.
Yeah, I think that's the ultimate goal. So you've done a great job talking about the biomarkers, the promise, the pitfalls, and the potential. And really, you hit on a lot of the diagnostic challenges we have with these patients. If everyone that was sepsis came in holding up a sign saying, I'm severe sepsis and this is my source, it would make it so easy for us. So can you talk a little bit more about the diagnostic challenges? We have linked on the slides for you as you're going through different literature just to kind of reinforce what we're talking about. So feel free to hit on that QR code. And if you could just talk a little bit more about the diagnostic challenges.
Yeah, I would argue the two biggest pitfalls or challenges, actually, I shouldn't say pitfalls, challenges. So external pressure. What are we being mandated to perform in the effort to quote unquote help or get the best outcomes? We know that the federal government dictates reimbursements on different codes. Once again, they expect a particular performance, and I understand that. We want our patients to do well. But when you look at this, SIRS can look like sepsis, pancreatitis, ARDS, both primary ARDS, which is pulmonary, and non-primary or secondary ARDS, pancreatitis, severe burns, a variety of things. They can all present the same way. Fevers. Well, why is there a fever? Because there's a cytokine cascade stimulating the thalamus to raise your temperature. Burns, you have a destruction of your tissue. You will likely get an infection down the road, but do you have it on day 2? Trauma. The trauma is a shock state. Of course, all of these are non-infectious. And yet, when in the emergency room, we're expected, based off of a quick evaluation, a risk assessment, and a positive test, which may be a lactic acid that's 2.3. And then there's this expectation that we're going to utilize antibiotics and fluids and a variety of things to improve their overall outcomes. But it turns out that fluid, the magic 30 mLs per kg, has not actually borne out the promises that it gave us. So you have to understand the big picture. And one day I think we're going to be there, but right now I don't. And I think it's working within the structures that we have present and doing the best job that we can of at least articulating what we saw and why we chose to vary. I think that that's probably the most helpful part. Just glancing at this sepsis, severe sepsis, and septic shock. Ultrasound when I was young was literally the size of like 6.5 feet tall by 4 foot wide machine that I had to wheel to bedside. And it was used in the FAST exam for evaluation of trauma patients. That was the first time I had ever used ultrasound. And I was a first year intern. Fast forward, we now have handheld ultrasounds hooked into an iPhone or an iPad that is readily accessible to nearly everybody. Why is this important? Because we can gather very quickly basic answers. I'm not talking a grade 1 through 100 and we're expected to know, is it 51 or 50? But it's high, normal, and low, or yes, no. These can be trained in a very short period of time. And this is where the assessment of your patient can go to the next level. I give a lecture called this ultrasound is the stethoscope of the 21st century. And I've been giving that lecture for 15 years because it truly is the opportunity to look at the heart function, the intravascular volume through the IVC, then put the patient, the risk, and the assessment together to understand how to best manage them so that I can more accurately go into this Venn diagram and find the severe sepsis and septic shock and how to appropriately manage them and the risk of increasing their antibiotic exposure, the excess fluid that they get that leads to organ injury, the chloride exposure that has been shown to cause kidney injury. Sorry if I sound so passionate, but it's a calling.
No, I think it's wonderful.
It really is.
So what I'm hearing from you, the key takeaways, there's not a magic bullet here. There's not one biomarker that we can say we can do this test and, then we're going to do this treatment with it. But there is some value in thinking about this biomarkers in panels. They seem to have higher accuracy. I love that you brought up using procalcitonin as an antibiotic stewardship tool. I am the one that, I'm the quality person. I'm very passionate about the SEP1 core measure. And we do talk about getting those antibiotics started early. But it's also great to have this discussion about what are we doing with those antibiotics and how does it affect overall doing the best thing for the patient. And we don't want to throw broad spectrum antibiotics to everyone if that's not what they need. And then other things to think about, just our resources being limited and the cost effectiveness that I feel like you touched on really well. So I'm going to let you talk a little bit more about this procalcitonin and the management of sepsis and how it affects our diagnosis, our prognosis, our monitoring, and even a little bit more about antibiotic stewardship. And then we'll lead into a really specialized population that we see in sepsis and mortality, and that will be the elderly. So I'll just let you take it from here.
I appreciate it. And hopefully I'm not redundant, but I will try to articulate a given message so that it really strikes home. When you look at diagnosis, procalcitonin is outstanding. As I said, though it can be released in areas such as malignancies, lymphoma, leukemia, and a variety of others, and trauma or iatrogenic trauma surgery, its role in bacterial infections is clearly indicated in the literature. You find a patient that has high risk or moderate risk, and we recognize that sepsis is a big killer, high morbidity, high mortality. Early intervention is critical. So I don't want you to take away from this that I'm skeptical of aggressive approach on the front side, but I think we have to understand the patient population or the person in front of us. In the ICU, I will have families say, is my mom or dad going to live or die? What's their percentage? What's the likelihood? And I say to them, it's 100%. They are either 100% going to live or 100% going to die. I don't look at one patient and think statistics. That one person to me is one or the other, and I'm trying to make it live. But if you talk about a population or statistics, which help guide you globally, when you start pushing patients into moderate or high risk with sepsis and septic shock, creating 20 to 50% morbidity, mortality, we want to err on the side of caution, put those antibiotics maybe up front when your procalcitonin is up, and then reassess that biomarker in 48 to 72 hours to understand, because if we're treating the underlying problem, that stimulus goes away and our procalcitonin will begin to have itself. And so there is great literature out there, not only about the utilization of procalcitonin in the outpatient setting, the inpatient setting, the ICU, utilizing that tool to initiate or diagnose infection on the front side. Prognostic, we know that the higher that procalcitonin is, the more likely as a population they are to die. Maybe then when you see a procalcitonin that's 70, you have to start being even more aggressive. Maybe you were hoping you could treat them without surgery for that perforated bowel. Maybe you talk to the family and say, if we don't do something, though risky, we know that their outcomes are going to be poor, right? So it may help guide actual treatment decisions. Monitoring, as I mentioned, if we're appropriately managing the stimulus, then we anticipate that procalcitonin isn't going to keep climbing. It's going to begin to halve. And so that's how we monitor. And then lastly, maybe we anticipated the patient was going to need 10 days of antibiotics, but that procalcitonin is back to normal on day 4. Why do I need 10 days? They have no fever, their blood pressure is resolved, their lactic acidosis is clear, and their procalcitonin tells you that the infection is under control and gone. And so there is very clear literature in the outpatient setting. We used to talk about antibiotics, the magic 7. I always love the history. Do you know why we talk about 5, 7, 10-day antibiotic regimens?
I don't think so.
Okay, you go into the clinic on a Monday. Well, 5 days is Friday, right?
Okay. Okay.
So now I can check back. You can check back on Friday. You're better. Okay. 7 days gets you through the weekend.
Mhm.
Come back on Monday. 10 days gets you through 2 weekends. There is no science to that. And so the old premise of 5, 7, 10 days of antibiotics isn't founded necessarily in science. And so we're now finding 3 days may be just as good as 7 days for certain infections.
Mhm.
Not all, but certain infections. And I think it's just really important to understand part of science is to question the science.
Right.
You
I
had,
really,
how is it that things got identified? How was it that they started? Did you know? What's a normal temperature? 98.6, right?
mhm.
Well, when was that actually identified and why was it? And why is it that the average body temperature isn't 98.6 now, but lower?
Uh-huh.
Because when they were doing it nearly a century ago, the average population had more parasitic infections, more untreated problems because of when they tested it. Now, in a first world country, people aren't living with these chronic problems. Our average body temperature, they speculate, has dropped because of that.
I really like the way you individualize and personalize the care to your patients. And that really is apparent to me as you talk, because you're thinking about this patient may already have something going with their liver, already have kidney problems, or they may need antibiotics for 3 days versus 5 days. I think that's wonderful, the way you're personalizing the care. And so now we'll switch into the elderly patients. And that is one, we see UTIs, for example, and we've got it there, the leading cause of infection. Often we'll see this patient. I know you've seen them plenty of times in the ED. They come in, they're sweet, they're, really easy to get along with, and all of a sudden their personality changes, they get confused. One of the first things I think is let's get some urine on them. But there's also that connection there of having that UTI that does turn into sepsis. And as you mentioned, we have some of the best healthcare in the world. So how do we have people dying from UTIs that are, in our hospitals? So can you talk a little bit about the difficulties of diagnosing sepsis in our elderly patients and how they don't present the same way as someone in their 20s?
Oh, I think you just opened up Pandora's box. Okay.
I know.
So I'm going to push back a little bit, and I hope you don't mind, is a
Please
collegial discussion. So the first thing you have to ask yourself is, what's the difference between contamination, colonization, and infection? So let's just start with that, right?
Mm-hmm.
So for the sake of this dialogue, I'm going to do more talking, but contamination is where you sample the exact same location multiple times, and you either get different pathogens, or sometimes you get a pathogen and sometimes you don't. That's a contaminant.
Mm-hmm.
Blood cultures.
Oh, yeah.
Skin flora, right? Staph epi.
Mm-hmm.
1 of 2 bottles is positive. Patient's afebrile, no signs of infection. So that's probably a contaminant, right?
Right.
Now, colonization is a little different, which is I sample the same spot over and over. I get the exact same pathogen, but the tissue locally is not invaded. So it's a symbionts of that space. So these Foleys, these bladders get colonized.
Mm-hmm.
So when you sample them, you're going to get the same bacteria over and over. Does that mean that they're infected? We're not doing samplings of their bladder wall.
Right, right.
But what we're really trying to do is say, is there signs that this is either in the tissue or outside of the tissue, which means an infection? And this becomes very challenging because human nature is to say, this is happening and this is happening, and therefore they're linked.
Mm-hmm.
And I would argue a good chunk of the time they're happening simultaneously and have nothing to do with each other. Let's say grandma with the indwelling Foley gets confused.
Mm-hmm.
She comes in and you get their urine and it's dirty.
Mm-hmm.
We call it urosepsis.
Right.
Well, maybe grandma's got small vessel disease. Maybe grandma wasn't feeling great and quit taking in PO, and she got a little dehydrated, and she's got an EF of 40%. And that means that that decrease in intravascular volume actually then caused her kidneys to get a little dry. And there is crosstalk that goes on between the organs. And we know about cardiorenal syndrome and hepatorenal syndrome. And that's why we talked about non-pulmonary ARDS, the cytokine talk between the pancreatitis and the lungs. And so grandma may be having cytokines coming from the kidneys, not because they're infected, but because they're dry. And you give her a little TLC and a little bit of fluid. You change out her Foley just so that the bacterial burden's a little down. And you don't necessarily have to treat her with antibiotics. Your procalcitonin's normal. Can you have a procalcitonin that is normal and you have an infection? Yes.
Mm-hmm.
Because if it's a localized infection, you don't have enough tissue being injured to release the procalcitonin. So I have appendicitis, not a ruptured appendicitis, an early appendicitis. And your procalcitonin is normal. Does that mean that you don't have appendicitis? No, it just means it hasn't spread to the body to create enough damage for the procalcitonin to be elevated. So colitis, diverticulitis, appendicitis, all of these things, you have to put them in context. So please don't hear me say normal procalcitonin, you don't need antibiotics. I'm just saying to you that it's important that we look at our patient and understand that altered mental status and dirty urine in the face of a Foley doesn't mean urosepsis.
Right. Agreed. And I think it's what we were just talking about, that individualized care and understanding what's going on with your patient. Look at all your diagnostics. So we talk a lot about sepsis mortality in the elderly. We know it's 50 to 60%. Again, we're just connecting you here with some literature. If you want to look up with your QR code, a lot of my time and what I do in my job is looking at sepsis mortality. And could we have done anything differently? Were there any delays in care? Did we maybe go down the wrong pathway? And then we go back and look. We did those live looks and seeing could we have done anything different? So when you think about sepsis mortality in the elderly, what are your thoughts with that?
Yeah, so I see this slide and I see two things. First is that as we get older, right around 30 to 40, depending on the organ system, we begin to lose function. Mm-hmm. So we lose 1% of our GFR every year after the age of 30.
Mm.
But I also lose 1% of my muscle mass every year. So our creatinine at 30 and our creatinine at 80 theoretically should be no different. My muscle mass is decreasing at 1%. My GFR is decreasing at 1%. It's linear. And therefore, my creatinine baseline or balance stays the same. And so when you see a creatinine of 1.2 in a man who's 80, but his creatinine really was 0.6, it's not 50%, it's more like 25% because he's doubled his creatinine level.
Mm-hmm.
So I'm just talking a little bit of math, but at the same time, conceptually, I think it's so important to understand. So when I see this 50 to 60%, what it says to me is that just like the straw that broke the camel's back, we don't have the same reserve to overcome the insult that our body is undergoing. We have a more narrow window to intervene to get them in that space. Their reserve is less. So that's the first thing I see. So the older you are, the higher your risk because you don't have the same reserve. The second thing I see every time I hear this, sepsis mortality in a given healthcare system. Well, I was an ECMO specialist, was an ECMO director when I was in Washington Hospital Center. And in that process, we started looking at the Caesar trial. Well, the Caesar trial came out. So at the time, I was a fellow and we were doing ECMO. ECMO kills. 50 to 60% of people, regardless if you put them on ECMO or don't, die. And so the statement that was always made to me is that lack of evidence does not mean evidence lacking. What that means is just because the right questions haven't been asked yet doesn't mean that a service or skill won't make an impact. You have to ask the right question. You have to study the right question and get good results for the question that you asked. So the Caesar trial came out, which showed that patients transferred to an ECMO center had higher survivability. So does that mean that ECMO saved lives? Trick question. No. What it says is that a facility that it does ECMO probably has better care and services across the board, proning, ventilatory management, fluid restriction, early nutrition, antibiotic stewardship, all of which then improve the global care to that patient, whether they went on ECMO or didn't go on ECMO. And I think it's really important that when I see the sepsis element and I look at institutions that are doing well, maybe they're focusing, like the Hawthorne effect, right? Mm-hmm. You focus on something, you're more likely to get that accomplished. And so that's the two big things that I take out of this slide is pay attention that we have a smaller window with as people age because they have less reserve. And just be careful that it isn't the Hawthorne effect that you're really measuring, that it has to do with something that you're doing to lead to that outcome other than just observation.
Excellent points. So again, just looking at the literature and what's out there, we looked at a meta-analysis and brought this one to the module just for you as you're going through, but just to reinforce what we've been talking about, that utilization of PCT can have better outcomes, and also not to be redundant, but just how it can support the antibiotic stewardship as well. Is there anything else you would want to say on this slide that we haven't already said?
Yeah, there's so much literature out there, whether it be from the clinic, the urgent care, the emergency room, the floor admissions, ICU admissions. There is plenty of literature out there to keep people reading for weeks about the value, when used correctly, of procalcitonin.
So just wrapping this module up, we've touched on a lot of different things. And just with the PCT testing and antibiotic stewardship, there's the initiation, the de-escalation, and the evidence. So we talked about when you have those high levels that could support the need for antibiotics for bacterial infections. We talked about how that could improve your outcomes, how low or decrease in PCT can help to guide you, like you mentioned with the 3-day, 5-day, 7-day, and overuse of the antibiotics. And then the evidence. We've tried throughout the module to bring in different evidence to support what we were talking about. And just the clinical benefits, we've talked about the reducing the antibiotic use. We talk about improving the outcomes. We've had some great dialogue. I mean, none of this is cookie cutter. It's not easy. There's multitudes, multifaceted when you're trying to treat these patients that have sepsis or that don't have sepsis. And you brought it up, just trying to align. We want to do well with our sepsis core measures because it is value-based purchasing. Our administrators, they're looking at this number, but also at the end of the day, we want medicine before measure. We want to make sure we're treating each one of those individuals and doing the best things for them. Is there anything else you would like to add here?
No, I think that you did a very nice job of summarizing the process. And I think that to stick with a capitalistic approach, which is Toyota, right? Small incremental improvements and consistency are going to be the key to the end product. And I really do think that our dedication to sepsis is critical. I think that understanding what makes a difference and then ensuring that it's utilized over and over and over is critical. And I do think that our tools are going to get better as we advance. I'm a big believer that one day medicine will be a blood drop and an analysis through genomic expression, which is how does your body turn on and off particular genes for a given stimulus. And I really believe that there's going to be a point in time where we're not going to have vials of blood. It's going to be a finger stick, a test that will give us our answer within an hour. And it will say, these genes were turned on. This is going to be your cure. These genes were turned off. This needs to be avoided. I believe that there will be a day where it's going to be like the Jetsons, flying cars, except it'll be flying medicine.
Yeah.
Oh, I love that. So just key learnings and next steps. Biomarkers improve our diagnostics, but we want to be careful with those interpretations as we discussed. Procalcitonin is a safe, evidence-based tool. We've given you plenty of examples. We hope you will continue with these modules and go on to module 3 to hear from Dr. Bach. And we've got some great case studies there on navigating the gray zone. Anything else you would like to add?
Yeah. The last thing that I think I would say is I do think that panels are going to be the next step in this adventure forward. And the reason is that, as we mentioned, each test comes with its own characteristics, its own sensitivity and specificity, positive predictive value and negative predictive value. And you begin to harness, much like AI, the power of compounding. And so as you get to pair different tests together in a panel, I think it will generate a more effective answer, and it will be closer to what I said about the genomic expression for individual care. So I'm excited to see what the future holds in biomarker panels and its ability to generate improved outcome for our loved ones. Because the truth is, I got into medicine to help people. And that's probably why, if you hear, one, a lot of passion, but two, a lot of conflict, meaning it's the person in front of me that I want to help. I'm not working off of a population-based process. I'm working on one person in front of me. And a lot of fluid for one person is helpful. A lot of fluid for another person is not. And I don't want to do harm. First, do no harm. I don't want to do harm in the process of saying I'm doing it to help. No, don't walk that yellow brick road, right? Good intentions are paved. So there you go.
Well, I've enjoyed this conversation. I think I know a lot about sepsis, and then I meet other people that know sepsis, and I get the opportunity to learn a lot. So you're doing great things. This was an awesome conversation. Michael, I'll turn it over to you.
Great conversation, Amy and Patrick. Really wonderful. Up on the slide there are some readings that you two referred to as we were going through this. Obviously, there's a ton of other readings that are out there, but if you're interested, please go and dive deeper into what the two of you have been talking about. So thank you so much, Patrick and Amy. Great discussion. And hopefully for the learners, you'll join us for Module 3 in the continuing discussion of the gray zone for sepsis patients.
You know, as time went on, when you start in medicine, you know nothing, and you're really trying to learn it because you want to not only know it, but you want to feel smart. And then as you move through medicine, as you get into the later phases like I am, learning how to do less is hard because you feel like doing something. Don't just stand there, do something, right? But the truth is that much of what we do that is beneficial is not to do something. And so I coined a phrase, the more I learn, the dumber I get. Because the more I learn, the more I understand I don't know. And when I come into a forum like this, I'm here as a student to be taught by Amy and Michael as much as I am here as a teacher. Because I think if we keep our brains open, somebody has something that I don't know. And I want to steal it from them.
That's right.
Great advice. Absolutely great advice. Thank you so much, Patrick. And thank you so much, Amy. This has been a great discussion.
Thank you.
And can't